All right, class, welcome back. And today we are starting a kind of a long series on cardiac patient management. And we're going to talk first about the assessment of these folks. But understand we're going to have several videos in this particular one. And so with that being said, I'm trying to chop it up into bites that you guys can actually be involved in and don't go too long on these. So we're going to talk about the assessment of the cardiovascular patients in these slides. We're going to talk about the management, and then we're going to talk about specific cardiac emergencies in that. So as we go through the slides, understand that we're kind of following that particular pattern. Now, so let's talk about assessing a cardiac patient first. I think that let's go to the patient assessment. That's what we do. You're right, and we do, but there's some things that we kind of key in on if we believe that it's a cardiovascular problem. And notice that the two words there, cardio, heart, vascular, blood vessels. So you got to understand, you got to be ready to do both as needed. Again, the initial start out is the same. Is scene safety, get your level of responsiveness, your APU scale, airway, breathing, circulations. Again, when you're noting the breathing, pay attention to the patterns of it and any breath sounds that may be causing a problem with this. And the big one that I'm going to kind of focus on is the rails. If we're hearing rails or crackles, we've got a fluid backup problem. And we'll talk a little bit more about that when we get into the heart failure, cardiogenic shock. And then the circulation, again, I've always said this, skin signs tell all. Note the temperature, the color, the moisture, and especially at the extremities, because a lot of the times everything in the central will be okay, but when we start going down towards the feet and the legs, you put your hands on their feet and then they're ice cold. Again, the body's not circulating the way that it's supposed to. And these are, and again, treat your life-threatening problems. Again, if they don't have a pulse, they don't have a blood pressure, you got to treat these things. If they're having severe shortness of breath, there's a problem with the airway or the breathing, you got to fix it. All right, so the biggest thing that we normally get when you are dealing with a cardiac patient is patient's got chest pain. All right, they got chest pain. All right, and again, when we're taking a chest pain history, I think OPQRST becomes a huge tool for us to figure out what's going on. And if it doesn't, it gives us clues to what the underlying problem might be. One of the things, guys, when you have chest pain, don't forget that there's other organs in the chest that cause pain. Lungs, thymus. It's not normal, but they do, okay? So understand that before you start, okay? Understand that before you start, that there's other things that can cause chest pain. And those subtle clues is what's going to differentiate it between cardiac chest pain and something else causing the chest pain. The best example I can give is if you've got a dissecting thoracic aneurysm, you're going to have a tearing pain versus the pressure type sensation usually involved with cardiac related ischemia. So again, shortness of breath. When did it start? What were you doing? Was there exertion involved? That one I would definitely we kind of have to be a little creative when we ask that question. The duration, compared to pain, again, how long did it last? Is it continuous? Does it go away and come back? Okay. Provocation, did you do something that provokes the pain? Is it, again, that exertional, non-exertional? That's kind of a big one. Your body, your heart, if you're using more fuel, if you're using your muscles, it requires more oxygen. And if you speed up the heart and cause it to squeeze harder, it's going to eat up more myocardial oxygen. So if you start having pain there, again, you've got a problem. And again, if they rest and they go back to normal, again, now, by the way, is it a sign of a bigger problem? Absolutely. But again, they may not be an emergent patient. It doesn't mean that they don't have something serious going on. Orthopnea. If they have to sit up, and orthopnea is kind of a big one with me. They sit up. If you try to lay them down and they will not do it, okay? Again, that is a huge problem. The cough. Do you have a dry cough? You have a productive cough. Productive cough, you're thinking probably more towards a lung issue. Again, dry coughs, usually it's the body trying to open up those alveoli to get additional oxygen in, but it could be a sign of a cardiac condition. All of these things on the list here, all of them can be a reason to having a cardiac event, okay? All of them can be, okay? The anguish, by the way, and I've stressed to you guys when we've talked about assessment before, anguished facial expression, the feeling of impending doom. When they look at you and say, I'm gonna die. If they got nausea or unexplained vomiting, and I mean, look, I haven't eaten anything in 12 hours and I'm throwing up like crazy. Guys, be thinking that it's their ticker. Be thinking that it's something cardiovascular in nature. Again, allergies, medications, find out what they're on, including the non-prescribed drugs. Antihistamines can cause a certain degree of chest pain. It can also kind of lead us towards, they use them as a cough suppressant. Again, cocaine use is kind of a big one. Alcohol will give the sensation of chest pain as well. It's usually gastrointestinal related. However, remember your esophagus runs right by those areas, okay? As well as the alcohol can have cardiac related potential problems. It can cause chest pain. That's why your drunk guy starts having chest pain, because again, the vessels kind of tighten up a little bit. You would think that they wouldn't, but they do. All right, past medical history. Again, find out if there's something in their history that's going to lead you towards their having a cardiac problem. Okay? Again, if they're diabetic and they haven't been diagnosed with a heart problem, well, surprise, okay? By the way, elderly females, diabetics, the 3 danger groups, okay? Elderly female diabetics, all right? If they're all 3, they should come with 12-lead post already installed, okay? You really need to be thinking heart, especially if they've got a weird symptom that is not explainable. Last oral intake, especially caffeinated beverages. Guys, I've seen people drink bangs and energy drinks to the point where they actually go into supraventricular tachycardia. Yes, it can happen, okay? And then events preceding the incident, any type of stress, strenuous activity, sexual activity actually. Yeah, that's right, you got to be healthy enough to do that. All right, so when you're doing a physical exam, usually we do it at a 45-degree angle. And we want to inspect, again, the trachea where it's at. We want to inspect, again, make sure we're not having shifts in the trachea. What we're really looking at also is looking for engorgement. You also want to actually visibly inspect the thorax and the epigastrum. You're going to have to do a 12-lead anyway, folks. Remember, that should be on a cardiac-related patient, thorax pain. That should be high up on your list of obtaining a 12-lead. So while you got them exposed, take a good look. Do your feels. Check the epigastrum. Make sure that we're doing what's supposed to happen. Make sure you're listening to breath sounds. And you're looking for adventitious sounds. Something that should be there and or should not be there. The adventitious is extra sounds that shouldn't be there. Your heart sounds, again, should be normal. And again, the different lub-dub is normal. Anything but lub-dub, again, we're having a problem there. Lub is, of course, your S1 sound. Dub is the S2. But murmurs also, or if you've got something wrong with the valves, you're going to have the 3rd and 4th sounds. S3, S4 sounds. Okay, Kentucky, Kentucky, Tennessee, Tennessee, Tennessee. So you're going to have those different sounds, that different patterns when you're doing it. Listening to the carotid artery for types of bruits. Again, if we've got buildup of plaque inside of the in the carotid arteries, this actually got more problems to do with stroke. But again, it can be a sign of the patient has systemic atherosclerosis. It's got systemic hardening of the arteries, especially when you got narrowing of the carotid arteries going up to the brain. okay? And it's going to sound like a swooshing type sound, okay? Normally when you hear a carotid, if you're listening for it, it goes along with the pulse, swish, pump, pump, pump. But you can hear a definite change in that sound with the barut, okay? You're going to hear a more swoosh. It's going to be like you're taking this straw right here. And, okay, that's fine when we blow through it. Okay, we blow through it and everything sounds okay. But I clamp that down. Okay, it's a lot harder. And you're going to hear that constriction in there, in that particular pipe when the fluid's trying to go through. Now, palpitations, okay? Again, you terminate the massage, and this is for the, you're going to actually feel the pulse up there, and you're going to feel it, again, you got to be careful when you're doing that. I would say probably not to do that. Again, just hold it there, maintain pressure for no longer than 10 to 20 seconds, okay? So if you're taking a carotid pulse, again, only on one side, you don't want to do it on both. Again, you're going to feel on the thorax. I want to make sure there's no crepitus. I want to make sure that there's no chest wall tenderness. And again, check the epigastrum, make sure that we got nothing abnormal going there. All right, so your basic life support. Again, ABCs, if they don't have a pulse, we should probably give them a pulse, right? But advanced life support, the things that we're going to do for these guys, ECG monitoring, vagal maneuvers. We're going to talk about the precordial thumb, and we're going to talk about, again, defibrillation, cardioversion, synchronization, okay? So all of these are treatments. And then, of course, you got your diagnostic 12 lead, which I think it needs to be really high up on your list, okay? The cardiac monitor is staple for ALS care, okay? Again, it's got our blood pressure, it's got our pleth wave. Long and the short is that nowadays, most every monitor comes with lead 2. Again, they come with the 12 leads. Quite frankly, if you're not putting all 12 leads on to a cardiac patient, my theory is that they got a pulse and a problem. All right, they get a 12 lead. Okay. So again, the quick look pads. All right. Remember, the cool thing about the quick look paddles is back in the day when we actually had paddles, you just simply gelled the paddles, put them up to the patient. I didn't have to hook up the hard wires. Okay. Well, the patches work the same way. So if I've got somebody who is unresponsive, who is pulseless or has a questionable pulse, again, put the pads on, all right? Pads give us that lead 2 look, okay? Again, if you stop and think about it, negative is up here, positive's down here, okay? If you've hooked it up correctly and you hook up the paddles the way that they're supposed to be, you're going to have a look in lead 2, okay? So again, it kind of kills 2 birds with 1 stone. But you really do need to get them on a more definitive lead, the placement of the leads, the 4 leads at a bare minimum, but then get that 12 lead on as soon as you can. Again, remember, turn on your machine, prepare the skin. If you don't have the electrodes on correctly, newsflash, they're going to fall off, they're not going to stick, you get bad cohesion, really bad thing. All right, so apply your electrodes appropriately. Again, one of my problems right here is they should be outside on the shoulders, and they should be probably down on his legs, or at least a lot lower on the abdomen, maybe just above the iliac crest. But again, if I'm doing a diagnostic 12 lead look, I want those limb leads outside they need to be on the legs somewhere, okay? All right, so check your ECG rate. Check that, make sure everything is going good, obtain a tracing. Yeah, that's right, we really do want to take a paper tracing. Okay, and as we all know, this is PQRST, the heart rate is 56. I've got a P for every QRS, R to R appears intervals, good. The P to P's look the same, the PR intervals look the same. Looks like a sinus rhythm to me, okay? Again, continue your ALS care, again, and start beginning your treatment. But it begins really with a good assessment of that patient. All right? So, poor signal. We've talked about these before. Make sure that they're on. Make sure that they're good. Make sure that before you put on the leads that the gel's not dried up, because, yes, they can happen. If you got a patient with a lot of muscle tremors, okay, you're probably going to have to bring those leads in a little bit so that we don't get as much artifact. Make sure that your batteries are good. Make sure that there's no broken leads. Guys, I understand that you don't want to go swap out the leads. But if you can't get a good trace, then why the hell do you want to take a look at it anyway? Okay? So again, if you can't, you got to have good leads. You got to make sure that nothing's broken. All right? Now, again, a vagal maneuver. Now, these usually we do these on patients with symptomatic bradycardia. All right. Other names that we could call it: Valsalva's maneuver, coughing, carotid sinus massage, and let's talk about carotid sinus massage. We're going to talk about that a lot more as we go through the slides here. The precordial thumb. Okay, indicated for a patient that you witness go into an arrest. It's actually probably really good for a patient that goes into VTAC right in front of you or VFib right in front of you. The idea behind it is that you raise the fist about 6 to 12 inches above the chest and you come down straight down on the sternum. It produces a slight electrical pulse to the heart. And the idea is if we can do this fast enough, then we can actually convert the patient without actually having to use electricity. We don't use it in pediatric patients. And again, 6 to 12 inches. Don't go rearing back and wham. No, that's not how you do it. Again, 6 to 12 inches. There you go. Bring it down. Okay? Now, I will tell you that I have had these work. But it usually works if they immediately go there and you don't have the paddles on. If you got the paddles on or you got the patches on, use the electricity. Okay? Now, we're going to stop it here because this is when we're going to go to something else. Real quick back, I thought we had the slides on this. I guess we didn't for this. The different types of Valsalva maneuvers, real quick. Again, slowing of the heart rate, having them cough is a vagal maneuver. Valsalva maneuver, blowing on something or squeezing down, feeling like they have to go take a poop. That is, have them bear down. Those are all types of vagal maneuvers, okay? The carotid sinus massage, again, we're going to go over it a little bit more later in the chapters, but again, you basically massage up and down on the carotid artery, only on one side. And the idea is that causes the parasympathetic stimulation. The problem with it, guys, is that one's kind of out of favor now. And the reason is, especially if they have stroke symptoms, if they have a history of carotid artery disease, or if they have carotid bruits. If they have some plaque buildup and we're over there rubbing it, we break that loose. We send an emboli into the brain, and then not only do we have a rapid heart rate, but now we've got a brain stroke going on, and that we just complicated the patient's problem. All right, so we'll talk about drugs on the next one, gang, and I'll see you then.